So hi, my name is Nidhi. I am here from Bangalore. I'm here to represent a startup that me and Geeta have co-founded. It's called NIRMAL. NIRMAL is a Sanskrit word for well-being or free of disease. And we are trying to work towards the goal of detecting breast cancer much earlier than any of the methods today can detect and make it a universal screening method. And I'll describe why we call it a universal screening method as against all the methods available to us today. So what motivates us to work towards this problem? Breast cancer is the leading cause of cancer death among women. We lose close to 500,000 lives to this. This is in spite of this being a disease for which we know how to cure it, and if we can detect it at an early stage, when the tumor is a few millimeter, there is 98 to 99% survival rate. In spite of that, in India, we lose at least 60 to 70% of the patients who get diagnosed with this disease. Even in US, the survival rates are 80 to 90%, which is still very high given the fact that there is a regular screening that happens in US. But this is where, as one of the speakers earlier was mentioning, India is where we are seeing these problems much more acutely than anywhere else, and hence the ideas, the innovations are coming from here. If you can move forward. This is what I was talking about. Death per incidence is 3 times more likely. A woman who gets diagnosed with breast cancer in India is 3 times more likely to not survive just because we detect it so late. We are not able to detect it early on. And this is what we are working towards, how we can detect it very early at a really, really low cost in a way which is portable, which means we can reach out to tier 2 towns, tier 3 towns, villages, primary health centers, because beyond top 20 cities, mammography is not even available, right? Clinical exam is completely subjective to who detects it. Also, the cancer has to grow 1 centimeter or more before it becomes palpable, which means with hand examination or any other equivalent device, we are able to detect. By then, your chances of survival have already started going down. Can we detect it when it is really, really a few millimeters? So that's what we are working. If you go next, this is what is being used today, mammography. Really painful, expensive. 90% of the women in India do not even have access to this equipment today, and hence we see the survival rate difference that we see here. Also, it uses radiation, which means after a couple of mammography screenings, the risk of women getting cancer from this alone goes up. Sonomammography, you need to know the location, which means you have to go through some other technology before, and likewise biopsy. If you click, you will see what we are trying to do. We are trying to use a thermal camera. So most of the devices use the fact that cancer cells have a density which is different from other body tissues. So this is, be it piezoelectric, be it X-ray, sonomammography, everything uses the fact that the density of tissue is different. What we are trying to use is cancer cells grow at a much faster rate than all the other adjacent cells, which means they generate, one is more blood flow in that part of the body where the tumor is present. Also the fact that it causes a slight increase, very minute increase in the temperature of the region. And by using a thermal camera of very high resolution, which means in one image we get almost 200,000 data points, and we are able to detect a temperature difference of 0.05 degrees centigrade. This is not something a human eye can process, right? That's insane amount of data. So we use machine learning to process this data, and we use 70 features based on the information we collect like that, and we give that to a clinician. We also give our analysis, and they can kind of observe based on that. This is a very portable camera. You can carry it in your hand, and you can take it to a primary health center. You can conduct screenings. You can plug it to a drone, and you can send it to the Himachal telemedicine centers that we were talking about. This device can go anywhere. It is 80% less expensive than a mammography machine, right? It has no radiation. No harm, your body is completely safe when being screened through this device. If you go next, there's a video I would have liked to play. This shows how simple this is, where there is a camera and the lady just needs to take 5 pictures. These are just 5 images taken. One is in the front, then 45 degree, 90 degree, on left side and right side. That is it. That is absolutely, yeah. Can you pause? So you see a thermal image, okay. This is the kind of images get taken. This is what the thermal camera throws up to us. The wider the region, the higher is the temperature. And when I say, I mean, you see a lot of colors there, but this is really the temperature difference between these places is like maximum of 8 degrees centigrade, right? And as I said, 0.05 degrees centigrade, we are able to detect. As human, you will see probably 4 or 5 colors, right? But in 8 degrees centigrade, we are seeing 8 into like divided by 0.05. I don't want to do the calculation on this stage, but that's what we see. So one simple principle, you would think that the redder is the region, that means there is cancer, there is no major red region, there is no cancer. So this looks straightforward, right? What is the big deal? Why do we need us? Why do you need to know 0.05 degrees centigrade difference? If you move next, here is why. So if you see the image which is marked high risk normal, you would see red region. So you would say this person has breast cancer, but this person did not. This person, it's a high risk normal patient, does not have a breast cancer. You look on the other side, you would say, yes, I see red dots, look, might be cancer, but no, this happens to be a benign tumor. These are the cases, traditionally, most of the startups who have worked in this space have not been able to crack. We have been able to crack this, and we have 10 patents in this area, which kind of highlight why we are able to detect when others are not. These are the cases why it is not as straightforward as it might seem that, yeah, color change, I can look at it, I know where the cancer is. We are able to detect these cases as well, which we have not come so far with across any other, be it inside research or in product, anybody else who is able to do so. Next slide, please. This shows some of the results. We did some of the data collection and trials with Manipal Hospital. We have done 2 kinds of trials. One is where we looked at these images. We showed them to trained thermographers. Those are the people who are trained to read these images and be able to tell whether there's a cancer, benign, malignant, etc. Sensitivity, we got 100%, specificity 98.5%. This is a result, I mean, when a human reads it versus when a machine learning algorithm reads it. We went another 1 step ahead, and we said, let's look at it as compared to mammography results. Are we able to detect? Thermologically, yes, we are able to detect, but let's see what mammography says and what we say. And you can look at our sensitivity, specificity numbers. They are in the range of 90% plus minus. Again, we don't know of any other work in this area which has reached sensitivity, specificity above 60s, at most 70%. So this kind of shows how we are way ahead, and this is kind of probably give you a sense of what gives me confidence that what we are doing is really good, and I'm so passionate about it. So we collect a lot of data, menopause related data, your last LMP data. A lot of those data get collected by the clinician at that time, and we make use of that while training our algorithms.
And you also measure temperature just before, the core temperature before the scans?
We look at the temperature here. Right, so that is usually, because the skin is more exposed, one is we do a lot of cooling. So before you take the test, like BP, right? A person comes running into the room, you're not supposed to take BP. Likewise this, you are supposed to, like the patient is supposed to be in a rested state for some time, and we look at areas, I mean, there are certain like armpits, normally at a higher temperature than rest of the body. So we look at the areas which are usually at a cooler temperature than rest of the body, and we benchmark with respect to that. So we do that, yes, thank you. This also points me to one of the adoption challenge we are facing, right? Because when we go to a hospital, let's say, and their question is, so it's a new technology, how many customers do you have? Okay, you have only a couple of names, right? So they don't want to trust machine, and that's a sense we have been getting from a lot of sessions as well. So we work with a team of thermographers. These are people who are certified to look at these images. They are trained. Right? There are training programs for people to, I mean, only the clinicians can enter it, not people like me who are like no medical background. So we work with those people, and you have an option of saying, no, I want a thermographer to also look at it and do this. But we believe going forward, given our results, very soon we should be able to get to a stage where we don't have to depend on a thermographer being there as well. So that's where we are aiming to get to. But yes, thermographers are, there is a kind of specialization stream, and we have 4 thermographers to the best of my knowledge in India, right? So you can imagine the extent to which techniques like machine learning are needed, because we expect 2.7 billion females will get scanned for breast cancer. First part you raised about FDA. So FDA has approved thermography as an adjunct modality. So why that is so? Because as I mentioned, the thermography solutions so far have struggled to cross even 70%. I mean, between 60 and 70 has been the sensitivity specificity. So you can imagine FDA is not going to approve it as a standalone. But adjunct, it is already approved. We are going to go for the FDA compliance, not this year, because we want to collect a lot more data because FD is an expensive process. So we will be going for that, but given the results that we have a confidence to believe that yes, we should be able to get it approved as an adjunct modality itself. On scaling, thermographers are because of initial adoption, because people who are hesitant to adopt this initially, as she mentioned, certification helps. That stamping that this person, there is a human looking at it helps, but we are not dependent on them. This is for people who want that certification. Initially, probably it will take us some time to get to the stage where people will trust us.
Because this is a
over and
serious
above
matter.
them.
You know, the cancer
Yes,
is a
I
serious
know.
matter.
Yes, and you are right. If we say somebody has a cancer, it's a grave matter. I mean, the family goes through a lot just because you have said that. So initially, probably that will happen. But think about it on a mass scale. If you are doing it, it's not going to be, for example, tier 2 town. You can't do 15,000, let's say. You can't do 15,000 mammography screenings. When you suspect, you will do mammography, you will do sonomammography, you will do FNSE. You will have to probably go through a lot of that, yes. At least initially that will be true.
But in our hospitals, when we used to do camps, we will go through the digital mammography for all.
But imagine only three women have to go through mammography
That's
now,
exactly what I'm
where
saying.
1,000 would have had to.
That's what I'm saying.
Yes.
I'm saying for
Yes.
the 3 you do digital mammography.
Yes.
That's what I'm saying.
Yes.